Well, I'm sure you as a doctor aren't simply going to be able to look at a patient and say, oh, you need a decompression, you need a fusion. There's tests that you must perform.
Yes.
I've heard of one called a myelogram.
Correct.
Perhaps you could tell me a little more about that.
Myelograms are a very good test. We still do them. The upside to a myelogram is it gives you a wealth of information. The downside to a myelogram is that you have a needle stuck in your back, which terrifies people, although it really shouldn't, because it's an exceedingly safe test. The dye, which is what we use in a myelogram, is changed dramatically over the last 10 or 15 years. The dye we use now is much safer, much better. And all the things you've heard about people having a myelogram, having headaches, having dye reactions and things like that, that's just really not that common. We typically, when we order a myelogram, we see the patient in the office that day. And it's not real common to see problems with them. You know, other than plain x-rays, which are helpful too, and they're, you know, of course nothing is inexpensive nowadays, but plain x-rays are also useful, and they're the cheapest of all of them. But excluding plain x-rays, the two tests that we most commonly order is an MRI or a CT myelogram, or sometimes both. MRIs is called magnetic resonant imaging, which you subject tissue to a magnetic field that changes the electrons. I'm talking like I know what I'm talking about. But when you stop the magnetic field, they reshift, they release a signal, and it picks it up and interprets it into a picture. It's really good for showing tissues that have water. It's really good for showing tissues that have fat. And it's really good for showing tissues that have neither. And the water and fat have different colors on an MRI. So for spinal cord, discs, nerves, spinal fluid in particular, an MRI is a very good study. It shows that. It shows bone marrow very well in the bones. But it doesn't show bone spurs very well. In fact, bone spurs on an MRI look black. And the problem with that is air looks black. Nothing looks black on an MRI too. So sometimes it's hard to tell bone spurs on an MRI. A CT myelogram a CT scan, let's use just a CT scan without the myelogram. A CT scan shows bone spurs very well. It shows bone very well. But it doesn't show the spinal cord and the nerves very well because they're soft tissue. So when you inject dye into the spinal fluid, you actually then can see the spinal cord and the nerves very well too with the CT myelogram. The reason that MRIs are more popular is because you don't have to have a needle stuck in your back. But a CT myelogram is still a very good test to do. We don't routinely order CT myelograms. I don't want people to think that CT myelograms are routinely ordered, but there are times that we order them and need them, and sometimes they need both, an MRI and a CT myelogram.
Tell me a little bit about electro-diagnostic testing.
Electro-diagnostic testing is really sort of a wiring check, is what I tell patients. What the main portion of a electro-diagnostic testing is EMGs. And EMGs stands for electromyography. Electricity, myo, muscle, graph, meaning they record it. That's really the short and sweet. And the way they do that is they use very small needles, even smaller than acupuncture needles, inserted into the muscles. And we know from anatomy that specific muscles are typically, that's the problem, typically innervated by certain nerves. So when we, in a normal healthy muscle that has no nerve damage, when you stick a needle in it, it actually just lays there. And then when you ask the patient to move that muscle or contract that muscle, it generates a specific kind of pattern. If you have a muscle that the nerve to that muscle is damaged, the muscle's actually irritable. It actually acts funny. So that when you stick a needle into it, you'll get what's called fibrillation, growling kind of activity. So then you know that, then you imply that if that muscle has that activity, that the nerve to that muscle is damaged, and that's why, and that sort of, you trace that back to where the problem's coming from in their neck or their back. The other part of electrodiagnostic testing is called nerve conduction velocities, or NCVs, which is where you actually check the peripheral nerves, the nerves, after they leave your spinal canal and in your arms and legs, to see if there's any compression elsewhere. People can have compressed nerves in their elbow, compressed nerves in their wrist. They can have them in their ankle and the back of their hip. So those will help you decide if there's nerve compression elsewhere instead. So the take-home message by that is, suppose you have numbness in your little finger and your ring finger. That doesn't necessarily have to be from your neck. It could be a pinched nerve in your wrist. It could be a pinched nerve in your elbow. So electro-diagnostic testing can help you with all that. The drawback of it is, if you already have nerve damage, okay, like for instance diabetes, it's just going to tell you that. It's not going to help specifically. The other problem with it is that they quite often are normal in people who have spinal cord compression. But there's other tests and studies for that, and in fact even a physical examination can help with that. So there's pros to MRIs, there's cons to MRIs, there's pros to CT myelograms, there's cons to CT myelograms, and there's pros and cons to electrodiagnostic testing.